My name is David Kooby. I'm a surgical oncologist at Emory University School of Medicine. I specialize in complex gastrointestinal surgery and focus on upper gastrointestinal tract. I'm full professor of surgery. I am the vice chief of staff at the Emory St. Joseph's location and the surgical lead for the northern arc in the Emory system. So when a patient comes to see me with a cancer of the bile duct or cholangiocarcinoma, or I get a referral of that diagnosis, first thing we got to figure out is what disease do they really have. Cholangiocarcinoma is potentially 4 distinct diseases. You can have a cancer of the low bile duct, which is actually closer to the pancreas, which would be handled with a pancreatoduodenectomy or Whipple procedure. You can have a cancer higher up on the bile duct that is at the base of the liver, and that is known as a hilar cholangiocarcinoma, or what traditionally Gerald Klatskin in the 1960s described as a Klatskin tumor at the base of the liver. You could have a gallbladder cancer, and obviously the gallbladder is part of the biliary system. And then you could have a tumor directly that grows within the bile ducts of the liver called an intrahepatic cholangiocarcinoma. And essentially, all 4 of them would merit different operative approaches. So the first thing you need to know is what disease you're dealing with. The second thing to determine, who's a candidate for resection. Well, the first basic principles of most cancer surgery are you got to name it, you got to stage it, and then you can treat it. And staging a cholangiocarcinoma is very important. The more aggressive you're going to be for a more advanced disease process, the more failure you're going to have. So then you're going to put somebody through a big operation. One of those operations I mentioned, liver resection with bile duct resection and reconstruction, or Whipple procedure. Well, you don't want to do that if they're likely to fail from advanced disease. So you look for lymph nodes, you look for peritoneal disease, you look for other sites in the liver. And if those are all negative, then you have more of a green light to proceed. Next thing, you got to look at the patient. Are they fit enough for an operation of this nature? It's one thing to do a breast biopsy on a patient who's 90 and in bad shape, but the next question is, are you going to do a liver resection or a Whipple on these patients? So you need somebody who's fit for the procedure. And then beyond that, you may find patients who have limited metastatic disease to the regional lymph nodes. Now, those are patients that if you can pick that up ahead of time, such as with a PET scan or an endoscopic ultrasound and biopsy, well, then those patients might merit a course of chemotherapy first to get them in better shape, or at least assess their biology to determine if being aggressive with doing one of the operative approaches that I mentioned before makes sense for that individual patient. So that's now expanding the criteria to allow certain patients who in the past might not have been candidates for surgery to go that route. Finally, after you've assessed the patient, gotten the imaging that's appropriate to determine if an operation is reasonable for patients at higher risk, maybe an elevated CA 19-9, or maybe not in great shape, and you want to be very sure that you're going to be able to get the operation done, we might start with a diagnostic laparoscopy at the time of operation to determine indeed if it is appropriate to proceed and there's no other peritoneal disease or other sites of disease. So the concept of which patient gets an operation for cholangiocarcinoma, I'll summarize by saying the first answer is figure out what disease it is, figure out what stage it is the next step, make sure your patient's in good enough shape, and then you can proceed.